Welcome to the Demonstrating Implementation Excellence stream of the SNOMED CT Expo 2022. My name is Ian Green. I'm the Customer Relations Lead for Europe and also the Global Clinical Engagement Lead, and I'll be moderating today's session. All questions will be answered at the conclusion of the presentation. So online attendees, please use the Q&A box to type in your questions to the presenter. And for those on-site attendees, we'll provide you with a microphone. So I'm pleased to introduce you to Julie Vindenes Schultz from the Norwegian Directorate of eHealth, who will be presenting terminology binding of the Norwegian cancer registries. So Julie, please proceed.
Thank you. Thank you so much. Yeah, you hear me? Yeah. So welcome everyone, and good afternoon, and thank you so much for spending your last afternoon here on SNOMED Expo listening to me on the topic terminology binding of the Norwegian cancer registries. I'm very grateful for being invited here and to beautiful Lisbon and to attend this beautiful event. So yes, my name is Julie Schultz, as he said. I work as a senior advisor at the Directorate of eHealth. And the Directorate is the National Release Center for SNOMED CT in Norway. My background is that I am a medical doctor with about 15 years of clinical practice after I finished medical school. I've been working as a general practitioner for 1 year, then a short while with internal medicine, and then I specialized in radiology, which we in Norway do after we finish medical school, as opposed to some other countries. And I have been working with at different hospitals as a radiologist up until I started my present job at the Directorate last December, so fairly new with the SNOMED, that is. As a medical doctor, I have been reporting to different registries. In my last job working with breast cancer, I actually reported to the Cancer Registry of Norway, which I will talk about today. And for those of you who have not engaged in reporting activities, reporting to clinical registries is a time-consuming activity. And it comes in addition to your regular work of diagnosing and treating patients, and it's often not highly prioritized. So when you have a lot to do, filling out forms to some registry is not the first thing you do. You may postpone it, and you might even forget it. If you're lucky, you'll get a reminder from the registry, maybe once a year. And then you receive a list of the 50 patients you forgot to report on last year. And so you just need to remind those patients and try to report them as accurate as you have, as possible. As it is today, reporting to registries is often not a part of your regular workflow. Many forms are still on paper, and they might also be quite extensive with a lot of information, detailed information, and not only clinical information, but information about patient phone number, address, when they arrived at the hospital, and so forth. Having experienced the frustration over this time-consuming and cumbersome process, I really want to contribute to making the reporting process run smoother and more automated. So these are the topics I will touch upon today. First, I'll talk a bit about the benefits we hope to achieve by using SNOMED CT as a semantic foundation for exchange of clinical data. Then I will tell you a bit about the Cancer Registry of Norway, and then I will talk about the terminology binding working process and the team involved. and then show you some examples. And lastly, I'll try to summarize what we have achieved and what we've learned this far, and which questions are still unanswered. So SNOMED CT is a key to data capture in electronic health records. And these are some of the benefits we hope to achieve with our work. I could go into details of all of these points, but really the potential of reducing clinicians' time spent on reporting is motivating and important benefit, I think. So in this presentation, I will use the Cancer Registry of Norway as an example of how we work with SNOMED CT and the terminology binding of clinical data. The Cancer Registry of Norway is a government-funded large organization which collects data and produces statistics of the prevalence of cancer in Norway. It is responsible for 11 clinical registries, and each of these registries are dedicated to one specific cancer form, and it collects detailed information about diagnostic procedures, pathology examination, treatments, and follow-up. And the last point here, that all medical doctors in Norway are actually instructed by law to report all new cancer cases to the registry. So the registry receive their information from a lot of different sources, and this image illustrates some of the sources and the notification process to the cancer registry, where let's see if I get the pointer, manage, yeah, the clinical notifications and the death certificates and the pathology reports are among the most important sources of data that enables the cancer registry to code and store data. When the clinical notifications are sent to the registry, they are sent by an electronic reporting service, which is not part of electronic health record as it is today. And today, each doctor needs to have their own individual personal login to report. So this is the working process for terminology binding we've established with 7 individual steps. First, we receive the clinical variables from the registry on a spreadsheet. And during the first preparation step here, we revise the variable, or we go through the variables together with the registry. I'll come back to this shortly, because we have experienced this first step to be very important success factor in our work. Then the team from the registry and the team from the Directorate work in parallel to find SNOMED CT concept, which captures the meaning of the clinical variables. Here we might use one SNOMED CT concept, a set of concepts, or a more complex expression constraint query. I'll soon show some examples. We mostly use what's called value set binding, but we sometimes also use meaning binding. Then we meet up for a consensus meeting, the 2 teams from the Directorate and from the registry, and we discuss our choices and we try to reach a decision together. After this, the next steps, modeling of new concept, quality assurance, implementation, maintenance, and updates are just as important steps, but I don't have the time to go through them today, so that will be not part of my presentation today. The working team involved is multidisciplinary, and it consists of consultant with expertise in SNOMED CT from the Directorate of eHealth, coding expert with competence in SNOMED CT from the cancer registry, manager of that specific registry, cancer registry, medical doctors such as me, technicians with IT competence. And so the competence in the team enable us to find solutions to complex and challenging questions as we go, without delaying the working process too much. So this is an example from the breast cancer registry. And to the left, you see how it looks for the clinicians when he or she is reporting on possible symptoms and signs of breast cancer. This is, of course, in Norwegian, but these are the symptoms. Here it says symptoms, yes, no, unknown. And then there's a list of specific symptoms. And these to your right are the extracted variables from this form. That's actually before we've done the first step, we've revised the variables. During the first step, the preparation step I talked about, we worked through these variables, and we try to avoid classification-derived terms such as other, you can see here, if possible. We also try to make the variables as precise and necessary as possible. We ask, are the variables being reported on? Is the data reused? Here you can actually see that we managed to avoid yes, no, unknown on the extracted variables. So if there's if the doctor reports any symptoms, then it's yes, and no symptoms recorded. It actually means no. So to the left are the initial variables before we have revised them. And I'll show you a bit about how we work. So one example here is one variable of a symptom, possible symptom of breast cancer, not able to retract inverted mammae. It's maybe not so easy for you to see because it's a bit light. But this might be a symptom of breast cancer laying just underneath the areola or the nipple. This is a quite complex bit of information, and we found it difficult to retain the meaning of that variable using SNOMED CT. So we asked the registry, is this variable really necessary? And the registry found that this variable was not being reported on, and it was not, the data was not reused. So this we actually could remove. I also talked about variables like other. We try to avoid as far as possible. So here we try to ask, what kind of other symptoms might there be of breast cancer that's not already included in this list? And the registry actually found that there was two other symptoms that was being reported here. And the one was ulceration of the skin of the breast, or the woman reporting a tumor or a lump in the armpit. And so actually we were able to remove other and replace it by two more specific variables. So that's kind of how we work. And this is to the left. This is where we started And so this is the final terminology binding. And you can see some places we just found one SNOMED CT concept, some places set of concepts, and some more complex expression constraint queries. And to the far right, I've actually also included the total number of SNOMED CT concepts that may be included and may be reported on for that specific variable one. So how did we do? This is not maybe a very elegant table, but this is an evaluation of how we handle the information from the diagnostic form of the breast cancer registry. It's only one example, and we have terminology binded other clinical cancer registry, but this bears as an example. Before we started, the aim of the work was to find SNOMED CT concept for all variables as far as this was thought to be useful. It's kind of a vague phrasing, but that was kind of the scope of our work. And we found 72 out of 102 variables. We found SNOMED CT for them. And the real number of allowable SNOMED CT concept to report on was actually 8,311 SNOMED CT concepts. There were no registry specific information, and as my colleague Julie Maria Ries talked about yesterday, the TNM classification derived variables were out of scope. We did not terminology bind them. And for those of you who are not familiar with the TNM classification, this is a cancer staging system used to describe the extent of cancer growth. And it's a very important medical tool, and it's used worldwide. And we were not sure how to handle this information. But after I made this slide, I heard the great news that there recently been a licensing agreement between the American College of Surgeons and SNOMED International to include the cancer staging system into the international additional release of SNOMED CT. Administrative information was out of scope. The data is collected in different ways, or in other ways, but it's just part of the picture, so it's just included here. So to conclude, we actually will manage to find SNOMED CT values for all of the variables in scope, which is yay. So what have we learned? Oh, goodbye. Let's see. There you go. The main points we learned so far on how to make terminology binding run efficient is really the importance of an interdisciplinary and a competent team. This enabled us to discuss complex, challenging questions along the way without putting too much of a halt to the work. And also the importance of reaching the decision together. We kind of own this together. And maybe one of the key benefits of this work as a side effect, so to say, is that we revise the variables to make them both necessary and more precise. And this concept provides value in addition to the use of SNOMED CT and will provide higher quality in data and more standardized variables. So I was invited here to provide you with a demonstration of implementation excellence, as the theme for this program theme is. We have already worked through 4 of the clinical cancer registries in Norway, and linked them to SNOMED CT, but they have not been implemented yet. It was supposed to happen this spring. It's postponed until November. So I don't really have a final implemented version to show you. But next year in Atlanta, Georgia, when I'm invited, I'll show you the implemented and final version. And I can tell you the rest of the story of what did not work and hopefully what turned out to be a success. So that's all. Thank you for coming and listening.
Okay, so thank you. Julie will now take your questions. So as a reminder, if you're in the room, you need the microphone to ask the question. And I'll keep an eye on the online questions. So do we have any questions for Julie?
Hi, thank you for your presentation. I'm Inge from the Dutch NRC.
Yeah.
And I wondered, in your introduction, you said, well, it's very time consuming, the reporting. And how do you feel this terminology binding can lower that time? Is it the idea that it's more automated data extraction? Or could you tell us a bit more about that?
How it can improve the time consuming part? Yeah. Well, a lot of, as I said, a lot of registries are still on paper forms, maybe many pages. And so you need to, that's time consuming to kind of put all the data in. And there's a lot of unnecessary data, or not unnecessary data, but things that I don't have to write as a doctor. But so just making them electronical will be helpful. But so in this solution, we want to make them as a part of the electronic health record and more structurized. So hopefully I'll record the data once, as when I describe the patient and my findings in the journal or in the record, I mean, then I hopefully just write it once, and then either the registry extract it or I send them, and so you don't have to plot it a lot. And then also it will be kind of in the same workflow how it was with my former job. We actually had to log into a different computer because of firewalls, and this computer was in another room from where I worked. And so after I finished my work, or maybe the day after, if I didn't have the time, I had to go to this other room and I make paper notes because to report to the registry, because I couldn't have the medical record there at the same time. And so it's easy to kind of also plot this wrong data because you have 50 patients before other patients before you report, and then it's kind of easy to confuse your findings. So I think there's a lot of points will make the data better and much more easy. Yeah.
Thank you very much, Julie, for your presentation. Kingling Wallin from the Swedish NRC. Yeah, hi. We sat at the breakfast table together. We have been doing some mapping also in Sweden towards the registry. We have made an attempt to look at the breast cancer registry, what we call quality registry, and we also look at the prostate cancer registry. Now with the breast, we had the discussion with the breast surgeon, and we were looking into mastectomy. And you know, in mastectomy, there are many procedures. You have the oncoplastic surgery, the reconstruction surgery. And in Sweden, they code it with what they call the Nordic codes, the KVO.
We have the same.
And often these procedures are like one procedure overlapping another procedure, overlapping another procedure. Then we have a difficulties there to what should we do with SNOMED, or is it SNOMED question, or is it information model, or should we now today is post coordination and so on. So in your case, have you experienced such a thing, and how do you solve it?
It's an excellent question. I wish it was an easy answer, but we have absolutely discussed this, and the surgical procedure codes might be overlapping, and well, we're kind of lucky, I must admit, in Norway with the Norwegian Cancer Registry, because they are very on to finding good solution, and they understand SNOMED, so we have good discussions to find good solution for this. So we are now putting SNOMED or terminology binding in the procedures. So we're putting SNOMED to the procedures, and we actually, I think, we haven't actually finished all of the procedures, but as far as I've seen, there are SNOMED CT concept for all of the oncoplastic procedures also. So I think it's maybe a bit premature, but I think we'll achieve. But I can take your, yeah, we can exchange. Yes, you get my email and I show you how this is really, because we have had a lot of discussions about this, and yeah. Do you want to add something to this?
No, just we are revising the plastic ones right now. Actually, I'm waiting for them to come more precise variables, and we have worked together before with you, and I think that we should proceed to.
We should absolutely, yes. Thank you.
Okay, so we're out of time.
Nope.
So with that, we'll conclude this session. So thank you, Julie. So online delegates, you can join another session through the event lobby. So thank you all. Bye-bye.